with the objective to support the translation of personal medicine research into practice and to create a network between European and African researchers. Sorry. My name is Maria Jose Ruiz. I am a medical doctor by degree, a member of the Europe Africa PerMed Consortium. On behalf of the Directorate General of Research and Innovation in Health from the Italian Ministry of Health. This directorate participates in different international initiatives on personal medicine and research. And with the other members of this consortium, we have selected this first webinar on cancer topic due to this is a major public research problem worldwide. It is expected to surpass infection disease as the leading cause of mortality in Africa within the next 2 decades. The webinar, as I said before, is organized by the Italian Ministry of Health in collaboration with the World Package of 5 partners. And first of all, I would like to thank all the speakers and all the partners and participants. We have an incredible lineup of speakers for this webinar, and the registered attenders so far is over 100 attenders. So I hope they can participate, and thank you very much to all of you. Then let's go to start to introduce you our speakers. Our first speaker is Lynette Kamau from the African Population and Health Research Center from Kenya, and she will introduce the EU-Africa PerMed project. Our second speaker is Professor Eric Apondo from the Oncology Department from the Heidelberg University Hospital from Germany. He has a background as a hemato-oncology, internal medicine, and he has also a lot of experience in medical ethics, palliative medicine, and also ethics of the novel gene technologies in medicine, and has a lot of experience in the involvement of patient and public and project development. His speech is about the ethical governance of personal medicine research, why and we need patients and the public. Our second group of speakers is Professor Giovanni Martinelli and the Professor Giovanni Marconi from the Istituto Romagnolo per lo Studio dei Tumori, Dino Amadori from Italy. As you say, cancer is a group of genomic disease that present with interpopulation unique phenotypes, and the prevention and personalized treatment on cancer have been driven by the understanding of genetic makeup of the disease, and mostly of not African population. For this, we have selected this talk because it's important to address the knowledge gaps in understanding the underlying genetic causes and genomic. So Professor Martinelli, that is the scientific director and medical doctor and professor in hematology, director of this institute, his main research and clinical activity involve the area of acute and chronic myeloid leukemia and myelodysplastic syndrome. And Giovanni Marconi research cancer was center of acute leukemia. There are very active involved in clinical research, conducting research at the local and national level. Our second group of speakers is the Professor Lucio Crino and Paola Olivi from the same institution, and she will speak about the retinoblastoma, that is the most common cancer in the pediatric population, and the Wilms tumor, that is the most common renal malignancy of children. Both with global disparities reported indicated high incidence in the lowest survival in the sub-Saharan Africa. Dr. Crino research interests include experimental studies on basic and clinical applied research and lung cancer also. He's also working in transnational research. He is coordinator of several European and international clinical trials and member of numerous scientific societies. Dr. Paola Olivi is a senior biologist and principal investigator on many research projects. She is also the chief biologist for the somatic molecular analysis performed by the Clinical Molecular Diagnostic Group. And she specializes in the area of predictive biomarkers to target therapy. So we will start with our first speaker. Please, Lynette, the floor is yours.
Thank you, Maria Jose. Good morning, good afternoon from wherever you are. Thank you for joining. I'm Lynette Kamau from African Population and Health Research Center, part of the consortium for the EU PerMed project, and I'll just be giving you a summary of the project. I will switch off my video just to save on bandwidth. Yeah, you'll be able to see my slides through the screen. Thank you.
Did you give any indication what the meeting was about?
Differential reason. I had someone speak. I'm not sure if they're addressing us or someone else. So I'm basically meant to set the scene for this particular webinar, which is to talk about personalized medicine and how it fits in addressing some of the challenges that are faced within is basically meant to first try and understand how personalized medicine is perceived within the continent, and with that understanding be able to integrate the project or the African continent and the work that's going on into the global international consortium for personalized medicine activities. I think the biggest challenge has been in the past, and for a long time, Africa has been considered to be left behind when it comes to personalized medicine. And so this is part of the efforts of the project to integrate and incorporate what's happening in the continent to the global efforts. Secondly, it's also to foster partnership and collaboration between Europe and Africa. And hopefully with that collaboration, a lot more can be done, whether it's in terms of facilitating knowledge transfer or funding or innovations and so on and so forth. The project is supposed to run for 4 years, started in last year in February and has been ongoing so far. And the main objectives for the project, as I mentioned in a snippet, is basically to identify who are the players on personalized medicine in the continent, and institutions, individuals, and companies, and so on. Secondly, it's to explore and understand what are the potential needs to advance personalized medicine in the continent. So this is really to engage stakeholders. The third thing is to now facilitate and foster the integration that I mentioned earlier with what's going on at the global level. But first, it's based on understanding what's happening at the African level and working with regional institutions such as the African Union to advance this. And then also to identify opportunities for synergy and how best issues to do with personalized medicine can be aligned with what's happening globally. So this can be from a practice point of view, from a programming point of view, or from a policy point of view. The other thing is to look at capacity needs. So are there areas that capacity needs to be strengthened, whether it's through training activities, and how best can the knowledge that is already there how best can it be transferred to the African continent and vice versa. And then also how best to enhance the awareness that on personalized medicine, how best to get people who are relevant to this area to contribute more or to understand more what their role can be in advancing personalized medicine. So we've had, and we have a work plan that covers quite a lot. So the first year, which is last year, we were able to do a bit of mapping work that's quite extensive actually, that looked at the policy landscape, the publication landscape around personalized medicine, and also the stakeholder landscape of people, of stakeholders working within the personalized medicine space. And quite interesting information emanated from that, and it culminated in a stakeholder workshop that was done early this year. Then the second year, which is this year, is now looking at, based on the discussions that we've had from the first stakeholder meeting that happened in February, how can we start now advancing the collaboration based on the insights that we learned? And secondly, how can we then start also translating the knowledge that already exists to feed into the systems that are happening within the continent? So we're looking at, for example, things to do with ethics, managing ethics around data protection, data use and management, and so on and so forth. And also looking at the policy landscape, what's missing either at the regional level and at the national level that could be a hindrance in how personalized medicine is practiced, or whether it advances or not. I should mention an interesting insight that came out from the stakeholder meeting was that a lot needs to be done at the regional level so that it can trickle down to African countries or states. So those are some of the things this project is looking to see how best to incorporate and working with different stakeholders. And then also there's a capacity element. We learned a lot from the stakeholder meeting around the capacity needs. So how best do we incorporate this feedback to ensure that, one, there's exchange and sharing between Europe and Africa, but also there's opportunities for identification of collaboration, and this collaboration is actually implemented throughout the life cycle of the project and also afterwards. And then other activities are based on the things that we learn and the information feedback that we receive, and all this mapping work that we've been able to do. How best do we communicate this information? So these broad activities are what will be implemented between this year and the end of the project, which is I think 2024, 2025. So with that, this is basically a map of the different stakeholders that are working within the EU PerMed project. As you can see, Africa is very well represented, and of course, Europe as well. But also the geographical landmark of the different partners within the continent is represented, and it's good because we get to benefit from information and experiences from different parts of the continent. And with this, we are also now able to have also an advisory board. And this is really a team of experts that understand what is required to advance personalized medicine and feed in based on their experience to the project, whether it's through their social network, whether it's through their knowledge around this area, and being able to add value and contribute to discussions that are established or initiated by the project. For example, we had Professor Michelle Ramsey present in the stakeholder meeting, and she actually had a lot of insights. The other thing is to look at what basically the project aims to achieve in terms of expected results and impacts is how best can as I mentioned, integration of African organizations be to the global efforts? How do we support wider adoption of personalized medicine standards to the African continent? As I mentioned earlier, sharing of data, samples, clinical trials, and things like that. Also, how does the policy landscape compare, or how can it be advanced to be seen in terms of what is happening globally? And in terms of medium term and long term, how best do we see and implement aspects that in fact enhance or reduce inequities when it comes to personalized medicine research and contribution from African continent, thinking about prevention, diagnosis, and treatment areas and issues. And then also, how do we see this project contributing to the global Sustainable Development Goals, Goal 3. And I mean, as I conclude, the main purpose again of this webinar is really to hear from people working in different countries and in different areas of oncology to just share their experiences around how personalized medicine fits in. And really the project aims to facilitate more dialogues like this so that we can learn from each other and be able to advance personalized medicine within the continent and facilitate the sharing in Europe and Africa and globally. Thank you. Please, if you want to know more about the project, you can access our social media and also our website. All the details are on this slide and they'll be shared with you should you need them. Thank you. Over to you, Maria Jose.
Thank you very much, Jeanette. Thank you for this clear presentation of our consortium. And now it's my pleasure to introduce you Professor Eric Apondo. Please, Professor.
It's Doctor.
Doctor, sorry, Doctor. The floor is yours.
Yet.
Thank you. It's your floor.
Okay,
Eric.
thank you. I hope the sharing is going to.
Yes, it's okay. It's perfect.
Excellent. Okay, good. Yeah, thank you very much for the kind introduction and hello to everyone from Germany here. I am going to be addressing the ethical side of personalized medicine. And I mean, the ethical challenges that face personalized medicine have been really extensively addressed in the literature. And I mean, we could make a workshop that lasts days or weeks if we just focus on the ethical challenges of personalized medicine. So, I mean, I have 20 minutes, so I'm going to try and focus it on just one aspect of that, and that's governance, governance of the data resources, which are important for driving really personalized medicine. And within this topic of governance, I'm going to focus on why patients and the public are important and why it is important that they're involved right from the beginning. I think it might have been mentioned in the introduction. I am, well, a doctor, an oncologist. That's my background, my medical background. But I also have a background in medical ethics. And what you see here on the slide on the left is the German Human Genome Archive, GHGA. That's an archive that was developed about 1.5 years ago. And I am piloting a project there where we're focusing on patient involvement, but I'm going to mention it also along the way during the presentation. So population level biomedical research is playing a huge role currently in shaping the clinical and the research landscapes today. There has, of course, been a focus on cancer and rare diseases. In the presentation, I'm going to focus on cancer. And two important drivers of the trend for population level biomedical research have been new molecular techniques like next generation sequencing or high throughput sequencing, and the evolution in the capabilities that we have in collecting, storing, and disseminating data, or big data, so to speak. And of course, very important in that landscape has been the development of human biobanks and genetic research databases. This has been abbreviated by OPEC as HBGRDs. And there have been, thus far, really significant improvements. I mean, if we look at just lung cancer, for example, and especially non-small cell lung cancer, the therapies that we were able to offer like 10 years ago were very limited and were limited to chemotherapies. But over the past 10 years, there's been a huge spectrum of therapies that have opened up: immune therapies, targeted therapies that are based on identification of gene variants within tumor samples. And a very important part of this discovery has been these huge resources for genomic and genetic data. But I mean, there's still a large group of patients who cannot, for example, be offered targeted therapies. There's still situations where we find that the same therapy for the same patient cohort does not work. So some of the questions that we're trying to figure out are, how exactly does treatment affect tumors? How does it affect, for example, the tumor microenvironment, the biomarkers that we're trying to target? So there's still a lot of room for improvement as far as that is concerned. Like I said, the HPGRDs, I mean, there are a wide range of resources, including registries, web-based platforms, databases, and more recently, there are archives, which are normally based within consortia. And there are many consortia that are already building platforms to enable international health data sharing. There's the International Cancer Genome Consortium. There are other consortia that are also focused on other groups of diseases, I mean, like cardiovascular disease and that kind of thing. And the ethical challenges that are being faced, or that have been faced since the beginning of biobanking, really have to do with data protection and protection of privacy, vis-a-vis the fact that we need this data to be available to as large a group of researchers as possible internationally, because only when these large groups of data are analyzed, only then is one able to actually come up with patterns that will lead to the development of diagnostic or treatment strategies that will actually affect patient lives. The other thing that's important, of course, is the return of incidental findings. I mean, how do you deal with a situation where you have taken, for example, a sample from a lung cancer patient, and then you discover many years from now, with new diagnostic methodologies, that they have some predisposition to another type of illness, which not only affects them, but also their relatives. I mean, how do you decide, or what are the criteria which can be used to decide whether you give this information back to the patient, what information is actionable? Do you decide to just give back the information when you know that you can actually treat the variant that you have found? Do the researchers have a responsibility to look for these variants? Do they have a responsibility to get back to the patients? How does that all fit back into consent? Because you also have to tell the patient about the fact that when you're taking the sample, that you might discover something, even if you can't picture discovering something outside of the diagnostics of the illness that they have. It's possible that it could come up in years to come. So there are a lot of questions as far as that is concerned. The other issue is benefit sharing, not just as far as the patients are concerned, but I mean, for example, what we are doing right now, the webinar, and the fact that we're trying to explore opportunities for sharing information between Europe and different entities, different countries in Africa. It's of course relevant to kind of see whether we have the mechanisms to make the benefits that come from the research, like the information that is the product of this research, whether we can explore avenues of making it publicly available, and what that will, of course, mean for the people who are investing in the research that is being done. One of the regulators, or one of the regulative mechanisms that have been adopted in the past 5 years to cope with this, or with these ethical issues, is the General Data Protection Regulation, GDPR. And the GDPR regulates situations where the data controller or data processors or the data subjects are within the EU. And it has already been used as a template for data regulation or medical data regulation for many countries and regions worldwide, but it still has limitations. And some of these limitations have to do with the fact that although the regulation should work within the EU, you still have the national boundaries that you have to consider. And of course, the social groups within these boundaries of within countries. And the other thing that also has to be considered is the fact that complying with the law does not necessarily mean that data use is ethical or that public trust is secured. And public trust is important for us to be able to attain the long-term goals that we're chasing after with population level research. And that brings us to the issue of social license. Social license basically comes from the idea that for some activities or for some entities, society has expectations that go beyond just fulfilling regulatory requirements. And there's an author who put it very nicely a few years back. Legal authority does not necessarily command social legitimacy. And there has been a lot of research that has been done in this sphere. And the idea is, at the end of the day, that the public wants to know, or the patients want to know, that when their data lands within a genomic data resource, that it's going to be used ethically and to their good. They want to know that they're not being exploited. And they want to have trust in the institutions that get the data. And it's important to think about trust from the patient or from the public perspective. This is just a snippet from a study that was done last year. It's called the Edelman Trust Barometer. It's actually done annually. And it was kind of interesting as far as science is concerned to see that there are a lot of people who believe that scientists design their research to ensure that the results support a particular agenda or for their own financial gain, and that the government can sometimes exert pressure on scientists to express support for particular policies. And that was not just in one country, that was in several countries around the world. And it's absolutely important. I mean, if you look down at the bottom, at the lower graph, within the health sector, it just doesn't just have to do with hospitals. It has to do with biotech. It has to do with consumer health and insurance. We're generally experiencing a situation where worldwide, people appear to trust science, trust the media, obviously, less. And when we're implementing such initiatives where data is going to be transferred between regions, it's absolutely important to also involve the public and the patients to make sure that this trust is not betrayed, or they do not feel like people are kind of benefiting monetarily from their samples without a tangible benefit really reaching the patients. There's a very good example of what can happen if patients in the public are not adequately engaged in such initiatives. And that's Care.Data. Care.Data was a program that was started in the UK in 2013. And the idea was to try and put together the big data that is within like general practitioner surgeries or in their clinics, to connect that with hospital statistics and make it available to researchers, to academic institutions, and see whether by combining this data, it would be possible to first of all, improve health service delivery, and especially come up with patterns that would help in prevention. So the program was started in 2013. And shortly after it started, there was significant criticism that came about from the fact that patients were saying they were not aware that their data was going to be transferred to academic institutions. There were situations where it came up that the patient's data also landed in the hands of insurers. And within a year or shortly after that, in 2014, it had to be stopped. They tried to start it again in 2015, and then it was completely scrapped in 2016. They're trying to revive it again. But at least as far as I know, at the end of last year, they hadn't quite managed. And the important thing that you have to think about is that this was despite the fact that they had a sound legal and technical infrastructure. I mean, everything that they were doing was legal. It wasn't that they were doing anything that was outside of the bounds of the law, but the issue was just that the public did not trust that their data was going to be used properly. So this is a summary, a pictorial summary of what we expect from governance. And it's a very complicated construct, governance. Trust is obviously a part of it. I've already mentioned that. It should be adaptive. Adaptive meaning that it should be able to cater for the fact that, for example, the research landscape is going to be different in 10 or 20 years from the way it is right now. And you should be able to come up with regulations right now that are going to be able to adapt to that. Yeah. And it should, of course, fit to the genetic database or to the biobank where it's being applied. And as far as trustworthiness is concerned, there are other important issues within that, like representativeness. I've already mentioned that, accountability and transparency, and the fact that it should be sustainable. So as far as public and patient involvement is concerned, the issue here is that the patients and the public, who are the donors of the data, don't want to be seen as passive donors, so to speak. There is an opportunity to involve them, especially at the beginning of initiatives, in designing and operating and coming up with the structures that are going to govern these institutions. It requires considerable effort, but it also has benefits. For example, as far as recruitment is concerned, and the retention in studies, transparency, like I mentioned, and representativeness. And I also mentioned that it's key to attaining long-term goals. And there are some good examples of institutions which have done this, like the Mayo Clinic Biobank has a community advisory board that advises on issues like consent and maximizing patient and public reach. There are also other examples, for example, from Wales, where they have a consumer panel that is very important with the public outreach initiatives that are carried out by the biobank. I'm going to finish by just mentioning some work that we're currently doing in this context within GHGA, the German Human Genome Phenome Archive. It was started in about 1.5 years ago, like I mentioned, and a lot of the functionality has not been taken up yet. And we're trying to make sure that patients' perspectives are incorporated in the governance structures and try and find out how they can actively participate in it. And one of the things that we're doing is making sure that patient co-researchers are also involved in the designing and conducting this study, and trying also to come up with innovative methods to qualitatively explore these perspectives. And the output is going to be a white paper that will concretely inform the development of the governance structures. And the idea is to really involve the patients in the different work groups within the archive. This is just a small picture of what we are trying to achieve. Trust is in the middle of it. On one side, you have the archive and the regulators and the people who are putting their data within the archive. Of course, that is all kind of governed by the ethical legal bounds of consent. And then you have the patient groups on the other side, and transparency, reliable oversight. And we're trying to make sure that all of that is kind of based on a foundation of good governance, where we'll try and make sure that there's good exchange of ideas between experts and patients, education of patients, and open up data access so that patients can see what exactly is being done with their data. Just shortly, as far as patient involvement in designing research is concerned, a lot of patient involvement in research doesn't go beyond consultation, where you just ask patients what would be interesting to know from a study. But what we're trying to do is make sure that we're collaborating with the patients and coming up with an ongoing partnership where they can really contribute in a sustainable manner, not just to this study, but to other studies that are also going to come up. And this is just a small diagram of the stages in the research cycle where the patients can be involved, from conception of the idea of the research to designing research, analysis, and implementing, putting into practice, publication and dissemination of research, and showing the public that there's actually a benefit to what they're doing, so that the results of studies don't just stay within the scientific community, for example, and they're not just shown at congresses and that kind of thing, but they should be available in language that patients and the public can understand on websites, for example, so that patients can, especially when they have donated data or samples to a biobank or a data bank, that they can see the benefits that are coming from their samples. So in summary, like I said, genomic data resources and population level biomedical research is key to research in medicine today. But there are still significant questions that remain as far as ethical operations of data resources is concerned. And governance has been seen as an opportunity to establish structures that are adaptive and acceptable to a wide range of stakeholders, including, or rather, and especially patients. And like I said, without this patient and public involvement, it will likely be very difficult to achieve the long-term goals that we are trying to achieve with population-level biomedical research. And like I said, there have actually been cases in which, due to a lack of patient and public involvement, initiatives have actually failed, despite the fact that they had good legal and technical infrastructure. So it's absolutely important, and it's important to think about it right at the beginning of initiatives, how exactly we're going to reach the public and the patients, how we're going to communicate with them about the fact that they're giving their data, and how we're going to make sure that the benefits that come from the research don't just stay within the scientific community, but they also get back to the communities of the people who are actually really the drivers of the research that is being done. Thank you.
Thank you very much, Dr. Apozdo. Thank you for this very complete presentation. And regarding the involvement of the patient, I think that from the personal medicine point of view, we are every day involving more and more the patient as in the several steps of the research. But it's clear that, as you have said, as researchers, as funders, we need to demonstrate the evidence of this benefit. And this is the most important part. Also, to take in consideration the complex ethical aspect of this involvement, because for the point of view of the researcher, we need to understand what is the level of this patient expertise for the different steps of the research. And from the point of view of the funders, we need to understand the economic human resource that has to be involved in this approach. Thank you very much for your presentation. And now it's my pleasure to introduce Professor Martinelli and Dr. Marconi. Please, the floor is yours.
Thanks a lot for the kind invitation. I don't know if you are able to see my screen.
Yes, but this is not in presentation mode.
Just a second. Is now coming or not yet?
Not yet. Now, perfect.
Perfect. So it is a great honor for me as a scientific director of Istituto Romagnolo per lo Studio dei Tumori Dino Amadori, which was the mentor of this institute, but was also a strong leader supporting the research in Africa, particularly in our hospital in Mwanza, but getting a great impact on transforming and making possible research at the level of Africa and Italy, particularly in Meldoli Hospital. So it is a great honor for me to present how we can do better in the future and how these personalized medicine approaches that the European community are strongly suggesting and supporting for integrating with the Africa project. And this is my disclosure regarding the company. So I will present a prologue of how we are in this moment as the Istituto Romagnolo per lo Studio dei Tumori Dino Amadori. Dino Amadori was a strong supporter for getting integration between Africa hospital and particularly in cancer fighter, fighting the cancer at a global level, not only in Europe, not only in Italy, but in Africa also. And this is probably associated with a more express idea to integrate the research, the clinical research on cancer with gerobiomics and exposomics, immunohematology. Sorry, there is some microphone open. Immunohematology, nanobiomics and liquid niche, osteoncology, radiomics and drug discovery and translational oncology. So our institute is just an example of what we can do at level of personalized medicine. We are currently following 22,000 new patients yearly and getting 77,000 new cases in 2018. And we are divided in different places of our Romagna, which is a guest house, which permit for surgeons and patients and for caregiver to follow the patient during the permanence in the main building Medulla in oncology for the hospital oncology, hematology in Cesena, and radioimmunotherapy in Ravenna. And getting these facilities, cell factory, hematology, radiopharmacy, robotic oncology pharmacy, bioscience, nuclear medicine, oncocardiology, oncology, radiology, radiotherapists, cancer register, and skin cancer unit. And this is the tumor site distribution, getting roughly 30% of hematology and the other 70% divided in breast, gastroenteric, urogynecological, osteoncology, and rare tumor and lung cancer. In our institution, which you can eventually check what by web-based EHR, we are totally digitalized in the following the patients with the log 80 and here's the same log 80, which is the platform, bioinformatic platform that we have in the hospital in Muanza, totally integrated, similar, completely sharing with us continuously by web machinery. And this is something that we can use as the first point to get the personalized medicine integration between Europe and Italy. And this is something that I would like to mention from the beginning, since we started to get the same database, the same protection of the data, the same ethical approaches, the same programs, and the same PDTA, how to follow the patients in Italy and in Africa in the same way. In 11 years of history, we get 18 new patients with 57,000 diagnoses, and we get a lot of procedure, medication, assessment, lab tests, more than 8 million of lab tests, 23 clinical trial recruitment. And of course, our grant office and transfer technology office getting an extremely high importance networking at the international level with the European Commission, for instance, but also getting approaches and grants from Innovative Medicine Initiative, IMI1, IMI2, National Institute of Health, OHE, Organization for European Cancer Institution, with Italian Agency for Promotion of Research at the European level, BBMRI and ERIC, biobanking and biomolecular resource research infrastructure, ECRIN, which is a European Clinical Research Infrastructure Networking, PerMed, which is the sort of umbrella for all the PerMed initiative, EATRIS, the European Infrastructure for Translational Medicine, and more relevant recently also the ERN Huracan for rare adults solid cancer, European Reference Network. And at the Italian level, we get a similar national networking parties, including Consiglio Nazionale delle Ricerche, Confindustria, Ministro of Sviluppo Economico, Minister of Health, Istituto Nazionale per la Fisica Nucleare, Alleanza contro il Cancro Network e Rete Alta Tecnologia of my region, which means that we need to get a networking infrastructure at the European level, at Italian level, and in the future also at the Italian Africa levels. And these open the collaboration of our institution in several countries in the world with ERN, Huracan, Maichi, Korea del Sud, Japan, China, Africa, but more important with the Mwanza Cancer Project, which was also recently published on Lancet Oncology. In our institution also we grow up another very important unit that is fundamental to get clinical research at experimental level with protection of the patients from safety profiling, but more important to getting more and more evidence of response, which is the phase 1 unit. In our institution, we started in July 2017, getting approval for clinical trial quality team. And you can see here that we get a progressive increase of phase 1 clinical study, including reaching something which is about 30 clinical trial of phase 1 and March and the October of 220. And recently, we also opened another infrastructure, which is very important, not only for getting health, but getting also economy coming from health. It is clear from the recent pandemic of COVID-19 that if you don't get health, you don't get economy. And let me say another point, you get a lot of expense if you don't have an economy who support the health of the entire country, including also Africa. So the Open Ears is our currently platform for innovation transfer, which means that we get from the research new innovation, new innovative, new patent, and we transfer this in collaboration with pharma companies and with oncology research, strategic and investment partnership. So our vision is to go in the core project to try not to try to avoid the problem, but to enter the problem, solve the problem, but solve the problem together. And that is the currently precision medicine integration model that we are developing in our institution and in general in Istituto di Ricerca a Carattere Scientifico in Italy and in Europe, is to get an external environmental assessment. Of course, we get genetical approaches, we get molecular and physiological approaches to get more defined in tumor genetics, microbiota, and imaging data sets, familial inheritage, cell-cell immune interaction, medical and biological data to get a sort of a human avatar, which made possible that in the meantime you cure the patient. In the meantime, you get also a patient pathway to get resistant, to avoid resistant to cure, to avoid adverse events, to get more integration in knowledge of the disease, archaeology and cooperation. And this is the line of treatment that we are currently conducting: outcome, value of the drug and function organization model, to the continuity of the diagnostic therapeutic rules of in oncology. We had 37 projects on this line 1. A second line, which is innovative therapy, phase 1, phase 3, clinical trial, therapeutic strategy based on preclinical model, 88 projects. Precision medicine, gender, ethnia, and geroscience, with a strong effort in genetic molecular mechanism development, characterization, therapy of tumors, 66 projects. And line 4, genetic environmental development, progression tumor, and inhibition mechanism, exposomy, primary and secondary prevention. All this line as just an example of which kind of integration in the personalized medicine between Europe and Africa we have to be able to produce, getting an advancement in the cancer knowledge and in cancer therapy. Recently, we also include in our development an robotic oncology pharmacy. And I would like to present this because in our hospital in Mwanza, recently we get a lot of efforts to integrate our currently pharmacy preparation of oncology drugs, pharmacy distribution, and pharmacy surveillance that can be compared between our institute and the Mwanza hospital in Africa. So it is possible to develop together potential integration of the preparation of new drugs in order to get vision on safety, efficacy, and sustainable research, innovation, development oriented in our country, but also can be done in the context of Africa. So there is many new integration that can be done, particularly in our institution, getting new scaffolds, new nanoparticle, new patch, getting more information from animals. It takes just the zebrafish model facility that we are integrating. But more and more important, probably, to get a somatic cell therapy lab with GMP facility, producing from the tumor and the apheresis GMP process, producing a new vaccine against the cancer. And this can be prepared in an individualized, but more important also in an industrial GMP capacity to be able to go back to the patient, which has to be done probably not only in one center, but due to the capacity to get a biobank and a hub and spoke model, we can develop the somatic cell therapy and the biological resource center biobanking integrated with other countries, including Africa. So I will move my presentation to the presentation of my colleague Giovanni Marconi. But let me say a final point. It is very, very intriguing and important at this level to find out the correct approaches to be able to respond to our patients, whatever is the country, from Africa, Europe, and all the parts in the world, to get a personalized approach, because this is what the patient asks to us every day, and we have to be able to answer in a correct and a precise medicine way to their necessary to fight the great cancer that still is present in our country, in our situation. Thanks for your attention. I move the presentation to Giovanni Marconi.
So, thank you, Giovanni. I'm here to just present open collaboration opportunities with our institution, because as a well-defined research infrastructure, we of course are available for partnership and for collaborative program, but also for in-kind support and to assist in research and clinical trial, whoever will ask. Finally, we are available for collaborating in grants and to plan knowledge transfer in terms of school and in terms of knowledge transfer in advanced biology and DNA sequencing. So. As Giovanni presented, we have a lot of infrastructure in DNA sequencing. That, of course, is the door to access personalized medicine and personalized treatment. And all the facilities that we have in home have a specific standard operating procedure and specific laboratory protocols for the analysis of hematological malignancies, solid tumors, and germline tumors. And of course, these operating well-defined operating procedures can be transferred to every institution who will request, together with the space for training. We are advancing our knowledge, and we are implementing in our laboratory the possibility to perform single cell sequencing and to perform other very advanced techniques. And it could be important in the future to participate together in a research proposal and in other collaborative efforts to define hematological malignancies, because even if advanced technologies like gene expression profiling or single cell sequencing are not useful for standard diagnostic and for therapy assignment today, of course, it can open new frontiers in the knowledge of cancer and in basic research. And we strongly trust that there is no research without basic research. And we are here to plan something that starts from the basis of the tumor and the ontogenesis of the tumor, and that help us to understand the mechanism of tumor genesis and the progression during therapies. Of course, with the laboratory, we can provide a lot of opportunities, as aforementioned, providing new technology for diagnostic, including next generation sequencing and genome analysis, but also at single cell level. And in a selected project, we can provide the infrastructure that will give genomic results and gene analysis results. And we can also help in providing biobanking facility and implementing procedures for biobanking facility and for genomic data maintenance. And it will be helpful at all in participating in research or grant and in collaborating in the international research infrastructure. Of course, we have also a bioinformatic unit, and everything that we are already performing can be transferred from the wet lab data to data interpretation. As a second thing, we are very active in clinical research. In particular, in hematology, we are participating in approximately 62 clinical trials today, including phase 1 trials that Giovanni mentioned. And we are gaining a considerable expertise in the use of novel drugs in the clinical trial and in the per-market access, as an example for expanded access and using the molecular tumor board. We are gaining also contacts with the company that can be shared to implement the research network of the pharmaceutical company and the possibility to perform a clinical trial for other hospitals. And we can work as an hub in the dialogue with most of the pharmaceutical companies that are developing in hematology. There are a few slides that present drugs with new mechanisms that we are currently using in acute myeloid and lymphoblastic leukemia, and it is intended as an example because also in multiple myeloma and lymphoma we have frontiers, and also in non-oncological or oncological chronic myeloid malignancies like polycythemia vera and myelofibrosis. The first drug that I would like to present is the menin inhibitor. We are developing a lot of these compounds with different pharmaceuticals, and they are useful for MLL rearranged or nucleophosmin mutated acute leukemias, directly inhibiting the dialogue between the mutation and the DNA. We are also developing the CD47 blockade as a third generation immunotherapy, and also in this context we are working with different pharmaceuticals that develop both CD47 blockage and CRP-alpha inhibitor in the macrophage side of the immune interaction. We are receiving third generation immunotherapies like TIM3. inhibitors that work on leukemia stem cell, and a lot of agents dedicated to the inhibition and the treatment of EDH1 or 2 positive malignancies in hematology, but also in solid oncologies. And a lot of effort we're putting in developing new strategies in inhibiting the FLT3 pathway. And of course, in every of these collaboration, there is open space for basic research, collaboration in clinical research, and also for post-market safety and post-market access. And also in acute myeloid leukemia, we are working in CD123, that is like a novel agent that is on the membrane of the leukemic blood cell with antibody drug conjugated. As aforementioned, we have a lot of space to work also with drug in lymphoma, and we are using the bispecific T-cell activators, the direct antibody, and as Giovanni showed, we have a CAR T-cell and vaccine production facility that we are finishing to build, and that will be open also for bulk production of non-specific, non-patient specific cell therapies. In the future, we would like to integrate for our vision all the available therapy in a genome-phenome strategy that directly is seen basing on its and laboratory results, different therapy, including chemotherapy, personalized target therapy, radiotherapy, metabolic intervention to the perfect patient, also using as an advantage the treatment sequencing and the combination therapy. And of course, a lot of work has to be done in this direction, but we will do this work in a strong international research collaborative network, and we are always happy to have new partners. From the clinical point of view, the opportunity will of course be to provide the company contacts and transfer infrastructure and standard operating procedure for clinical trial research, including the phase 1 clinical trial research. But as it is clinical, we are also open for remote consultation for rare cases and for mentoring physician, especially in the setting of achieving early drug access and early drug utilization for novel compounds. Together, it is possible to develop innovative personalized strategies and to design collaborative research. And the third topic, the third short topic, it is the innovation in cell therapy, because as defined before, we have a cell factory with a positive and negative pressure, and a lot of novel compound can be developed in this structure and can be frozen and transferred to every center in the world with mild logistic involvement. So for this reason, we will be open in the future also for personalized therapy in terms of immune activated directed allogeneic cells, and in terms of developing of hematology cancer vaccine after tumor selection and cell preparation. In this field, the opportunity, of course, will be of training for the preparation of immunotherapy at home, and of course will be of transfer, because most of the cellular therapy can be transferred both during development and of course after complete cellular development as a frozen drug. It will be possible to transfer standard operating procedure that we are preparing, and to transfer batch production of the genetically modified organism. Thank you for your attention, and we are open for questions.
Thank you very much, Professor Martinelli. Thank you, Dr. Marconi. Thank you for this illustration of your excellent infrastructure, and also for these important points on diverse topics of collaboration. Thank you very much. I think before we can go with the next telco, we can do a family picture. If you agree to turn on your camera, we can take a picture.
Okay, perfect.
Okay, I'll take the picture, Maria Jose. We have two screens, so it will take a few seconds.
And hoping that don't crash the system.
Okay. Okay, I think it's done.
Perfect.
Thank you.
Erika. Thank you, Joel. Then we can go to the next talk. Then it's a pleasure to introduce you Dr. Crino and Dr. Ulivi, who will speak about the retinoblastoma and Wilms tumor. Please, the floor is yours.
¿Y ahora? ¿Sí? Okay. Can you hear me?
Yes, please.
Yeah, perfect.
Yeah. As you heard from Professor Giovanni Martinelli, our institution has a long-lasting collaboration experience with the Bugando Clinical Center in Mwanza. Mwanza is one of the largest cities of Tanzania, and it is located on the Victoria Lake. During the clinical visit, which I have performed 5 times in Bugando Hospital, I was really impressed from the prevalence of advanced retinoblastoma and Wilms tumors in children in the Mwanza district. And many times we have talked with our friends and Tanzanian colleagues, Nestor Masaru, Eronima, Lucas, and Rina, about the possibility to develop and to design a clinical and a genomic trial in retinoblastoma and Wilms tumor. Retinoblastoma, as you know, is the most common primary intraocular malignant tumor in children, with an incidence in USA around 1 on 15,000 live births. And the average annual incidence in USA is around 11.8 per million of children younger than 4 years. Retinoblastoma is a familiar disorder with an autosomal dominant inheritance tied mainly to the mutation of B-allelic retinoblastoma gene. Retinoblastoma can be classified in different ways. We know that there is a familiar form, which is usually bilateral and heritable, and there is the sporadic form, which is unilateral and not heritable. Approximately 10% of newly diagnosed retinoblastoma are familial and 90% are sporadic. What was impressing me during my clinical rounds in Tanzania was the number of what I think are sporadic cases in the Mwanza district. This is the ancient classification Rees-Ellsworth with the new classification according to the diameters of the retinoblastoma, which is a tumor that is developing on the retinoblast in the retina. And most of the cases which I have seen in Mwanza, they fall in the more advanced group with poor prognosis features. Survival in retinoblastoma is usually compromised by three independent variables: the presence of distant metastasis, the presence of diffuse spread of retinoblastoma in both the eyes and in the brain, and the development of secondary metastasis of new cancer, mainly sarcomas. In Western world, the survival of retinoblastoma is over 90%. And recently, a lot of new techniques, mainly laser and radiotherapy, has been developed, moving away with chemotherapy at the early beginning of the disease, moving away from enucleation and external beam radiation therapy. However, in all the sub-Saharan countries, retinoblastoma seems to be associated with a high mortality rate, mainly because of the delay in first diagnosis. This is the clinical experience that our colleagues of Bugando, in particularly Eronima Kakashiri and Nestor Masalo, have performed and published in retinoblastoma setting of patients in Kilimanjaro Christian Medical Center in northern Tanzania. The patient population that has been collected, this was a prospective observational study, and the patient population has been evaluated in 1 year. There were 24 patients. Most of them, they do not have familiar story, so it seems to be sporadic. Most of them, 87%, are unilateral, and the clinical symptoms, the clinical signs are clearly the signs of advanced disease, with 41% of proptosis, 30% of swelling, and less present leukorrhea and redness. The stage of disease was mainly extraocular because of the spread of the disease, and in small percentage intraocular. What is important to define is that the delay of the diagnosis is quite always present, mainly is often more than 6 months, and with a median of delay of the diagnosis of 7.5 months. The histological picture of the retinoblastoma in the Kilimanjaro cohorts is clearly characterized by blue round small cells which are in high proliferation state and with a poor differentiation. According to the differentiation, most of the poorly differentiated patients are spread beyond optic or in the nerve optic and are extraocular. According to this spread, there is a possibility, important possibility of death, mainly in presence of extraocular invasion or beyond optic nerve involvement. The conclusion of this experience, which has been performed by Eronima and published, is that the majority of pediatric patients in northern Tanzania present with sporadic form, with extraocular manifestation and poorly differentiated high-risk features. The majority of these children has received enucleation plus chemotherapy, usually vincristine, platinum, carboplatin, and etoposide, and radiotherapy. However, despite the use of multimodality treatment, which in any case has obtained a good survival rate, most of the patients died and the mortality remained high because of the advanced disease presentation. So this is the background on which we would like to develop a clinical trial in the MOANS area to define the early incidence, the really early incidence of retinoblastoma at Bugando Hospital, to evaluate the clinical characteristics at the diagnosis, and to study the present strategy of treatment and its outcome. At the same time, we would like to collect histological samples for genomic and molecular analysis. The study that we would like to realize and to develop in the next few years is the study about which we have talked so many times with my Tanzanian colleagues. That is to do an analysis of prevalence at the present time of retinoblastoma in Bugando, to do a retrospective evaluation. Just this morning, we have a talk with our colleague in Tanzania and with our co-workers that are from the National Cancer Institute of Romagna, and at the moment they are present in Bugando, to retrospectively evaluate the number of retinoblastoma cases in the last 2 years, and to do a retrospective analysis of treatment in terms of response, progression-free survival, and overall survival. At the same time, we would like, on the basis of the information that this retrospective analysis will allow us, to start up a prospective observation of all new cases, performing a molecular profiling with next-generation sequencing in our institution, with particular attention to the immunological profile, mutational tumor burden, PD-L1 expression, and potentially to design a new clinical trial on the basis of the molecular profile that we will be able to define in this setting. The clinical characteristics that we want to evaluate are this: median age at diagnosis, bilateral or monolateral presentation, clinical stage, the time elapsing from initial symptoms to diagnosis, and then the modality of treatment: surgical treatment, radiotherapy, chemotherapy, and overall survival. The endpoint, the main endpoint of this kind of study are clearly to better elucidate the epidemiologic characteristic and the geographic distribution of retinoblastoma in the Mwanza district. We know that in Tanzania, the potential incidence of retinoblastoma is probably the double of what you can expect. And this can be due to many environment factors that we don't know, and that I think is worthwhile to identify or to study. And so, as well as the geographic distribution of the disease, in order to identify the area of higher risk and to potentially perform a screening program in this area. The second aim is to improve the clinical strategy of treatment, so to apply the modern approach of treatment in terms of diagnosis, chemotherapy, and local treatment, with the final aim to improve the overall survival, approaching the actual usual Western standard. The same plan can be dedicated to Wilms tumors. Wilms tumors are the most common primary malignant renal tumor of childhood. The USA incidence is 1 on 10,000 children less than 15 years of age, with higher risk in Afro-Americans. Overall survival with modern multidisciplinary approach, that means chemotherapy, radiotherapy, and surgery, is 90% in Western world, But we know today that 25% of these patients, they have long-term side effects. So our plan is to develop a parallel trial in Tanzania, in Bugando Hospital, parallel trial to the retinoblastoma project, to evaluate retrospectively the incidence in the last 2 years of the Wilms tumors, and to perform a genomic analysis matching all the molecular profile of these patients with the clinical outcome, and to evaluate at the present time which is the clinical outcome of the patients with the present modality of treatment, and to develop a clinical trial prospectively evaluating all the new cases. These are the two projects that we are involved today and that we plan to realize in the next future in Bugando, and we are finalizing this moment the retinoblastoma project, and we are starting the retrospective phase of the study, collecting all the information and looking at the presence and the availability of histological samples to match the clinical characteristics with the molecular profile. Thank you for your kind attention. Now I will give the talk to Paolo Ulivi, that will talk about the potential involvement in genomic analysis in both the two diseases.
Good afternoon to everybody. And thank you very much for the organization of this. We have to take off.
Yeah.
And for the organization of this interesting meeting that I hope we have to see. Devi attivare il microfono.
Ah.
A moment.
Okay. Do you see my screen?
Yes, but it's not in presentation mode.
Okay. Okay. Thank you very much for the organization of this interesting meeting that I hope it will represent the starting point for future collaborations and projects. I'm going to talk about the molecular profile of retinoblastoma and Wilms tumor, in particular in sub-Saharan African patients. As Professor Cunot has already said, these two tumors are very frequent in sub-Saharan countries, and in particular, they are very frequent in children and in very young children. Unfortunately, these tumors are diagnosed often when the tumor is in a metastatic setting, and it precludes the efficacy of treatment and impact negatively the prognosis of these patients. Starting from retinoblastoma, it is an uncommon cancer of the eyes that is curable when diagnosed in its early stages. But if we look at the survival rate on the basis of income, we can see that in high-income countries, we have a survival rate of over 90%, whereas in low-income countries, the survival rate is about 40%. And it is mainly due to the median age at diagnosis that is about 30 months in low-income countries with respect to 14 months in high-income countries. From a pathogenesis point of view, every gene plays a crucial role in the pathogenesis of this disease. And in particular, we could have somatic and germline mutations of this gene. In the case of inherited mutation, we have one allele of RB gene mutated in all cells, and then we have a second event in somatic cell, and we have the inactivation of RB gene. In this context, with the inactivation of RB gene, we have the development of retinoma, and if further mutation occur, we have the development to a malignant retinoblastoma. In this case, in this context, we have a bilateral retinoblastoma manifestation. In the case of sporadic mutation, we need to have two secondary somatic mutation. And in this case, similarly to what I have just said for inherited alterations, with two mutation at the somatic level, we have in the same way the inactivation of RB1 protein, we have the development of retinoma, and then the malignant transformation in case of additional alterations. As Professor Scrinò has already said, these sporadic alterations are associated with a unilateral manifestation of retinoblastoma and are very frequent in sub-Saharan population. There is also a small percentage of sporadic retinoblastoma, 1.5% about, that are not, in which RB1 mutation are not seen, but we have the amplification of MYC gene. And this type of sporadic tumors are very aggressive, is a very aggressive disease. RB gene is localized in chromosome 13, and it is code for a protein, the RB protein, that play a crucial role in cell cycle control by interacting with the E2F transcription factor. If RB protein is inactivated, the E2F transcription factor is constitutively activated, and it induces DNA synthesis, cell proliferation, and so induce malignant transformation. We know different mechanisms of RB inactivation in human cancer. In retinoblastoma, as well as in small cell lung cancer and in osteosarcoma, we usually see a mutation of the gene, mutation that induce the inactivation of the gene. Whereas in other type of cancer, for example, in breast cancer, in melanoma, in colon cancer, we usually see the phosphorylation of the protein that induces the inactivation of the protein itself. And for other type of cancer, in particular for cervical cancer, we have the involvement of viral infection, in particular HPV infection is involved in the inactivation of RB protein, because the protein E7 interacts with RB by activating it. And so this mechanism induces the cell transformation. This mechanism is well documented in cervical cancer, but there is evidence that also in retinoblastoma, there could be an involvement of HPV infection. You can see in three papers that was published in this context. The first one was published in Iran, and the authors found a positivity of 10% in retinoblastoma, whereas the other two papers were conducted in India, and the authors found a 25% positivity to HPV. And so all these tumors were unilateral, and so sporadic, and it could be very interesting to evaluate the impact of HPV infection in the retinoblastoma development in sub-Saharan African patients, where the HPV prevalence is very high. Moreover, RB1 could be not the single gene involved in retinoblastoma, but other genes could be involved. In this recent paper, the authors analyzed 24 patients that were RB wild type, evaluated by Sanger sequencing in MLPA, and were analyzed by an NGS gene panel of 160 genes. The authors found that actually 12 patients were RB1 mutated, and this is in line with the high sensitivity of NGS with respect to the other methodologies. But they also showed that 23 genes were mutated only in RB1 wild type patients, as well as they found some gene alterations, gene deletions that were present only in RB1 wild-type tumors. And so they suggest that this type of alterations could be involved in RB1 wild-type tumors. Another important aspect is that if we would make a somatic tumor characterization, we need to have available the tumor tissue. And in the case of retinoblastoma, we need that the eye have been enucleated. A possible alternative source, alternative specimens to make the tumor molecular characterization is liquid biopsy. Liquid biopsy is an alternative strategy for tumor molecular characterization. And in the case of retinoblastoma, a type of liquid biopsy that we could use is a aqueous humor that could be pre-elevated, and it could be used for molecular characterization. There are some papers that have demonstrated that this specimen could be usable for the molecular characterization and the monitoring of retinoblastoma during treatment. A recent paper has also demonstrated that also cell-free DNA in the blood could be usable for retinoblastoma characterization and for its monitoring during treatment. Moving to Wilms tumor, as Professor Queneau has already said, Wilms tumor is the most common renal tumor of infants and in young children. It's very common in Africa. And it may occur sporadically or in the context of bilateral tumors within specific genetic predisposition syndromes. And what we know about this tumor is that different genetic alterations are involved and different genes. We know that WT1 and W2X genes are involved in this disease, but also other alterations in p53 genes, CTNNB1, and DICE or other genes involved in microRNA regulation are involved. And recent paper, some papers in the literature have demonstrated that it seems that sub-Saharan African patients showed a form of Wilms tumors more aggressive with respect to other type of tumors that arise in other countries. In particular, in this paper, the authors compared a cohort of patients of Kenyan with respect to a North American cohort. And they shown that there are some features, in particular nuclear arrest and nuclear beta-catenin in epithelia, that are more frequently found in the Kenyan Wilms tumors with respect to North American one, and both are features of aggressiveness of the tumor. Similarly, in this other paper, the authors compared the North American Wilms tumor with respect to Kenyan, and they observed a different peptide profiles in the different populations, and in particular, they found an overexpression on FXR1 in Kenyan Wilms tumors with respect to the other. And FXR1 could be very important because its expression appears to be a marker of undifferentiated blastema and could represent a potential mechanism for cancer stem cell maintenance. And so it could be responsible for resistance to treatment. And in this context, FXR1 could represent a potential therapeutic target because if we inhibit FXR1, we could induce the differentiation of cells. What we are doing in years, as Professor Queneau has already said, we are moving to start a project in which we would like to study the incidence, the prevalence, and the clinical and molecular characteristics of retinoblastoma and Wilms tumors in Mwanza area. We would like to prospectively enroll all patients with a diagnosis of these two tumors, create a database with all clinical pathological information. We will collect all the archived FFPE tumor samples and also peripheral blood samples collected before therapy and during treatment. And of course, all follow-up information. At IRST, we have some possibility to perform a different type of molecular characterization. And so we would like to perform on this case serious genomic molecular characterization by NGS instrument, for example, whole exome sequencing or whole genome sequencing or methylation profile. We could also perform heterogeneity studies with the GeoMx digital spatial profiler platform. We could also perform gene expression analysis, sequential immunohistochemistry. We have all the expertise to analyze liquid biopsy and also to make HPV genotyping. The main aims of our project is to deepen the molecular characteristic of retinoblastoma and Wilms tumors in sub-Saharan patients in comparison with Caucasian patients, to define strategies to anticipate cancer diagnosis, to identify prognostic biomarkers and novel potential targets for treatment with the overall final goal to improve patient survival in these low-income countries. And thank you for your attention.
Thank you very much, Dr. Crino, Dr. Oliver. It's a very good job, and I think the presentation has demonstrated that you are doing a big effort to fight against this aggressive tumor. We have not so much time, but we have a question in the chat regarding the possibility of the data sharing. I think one question from Frank Onaibu, who asked if this database from the projects such as genome sequence could be possible to be available, published available.
Alitolewa Dean, apendi kukuja siku hizi.
Frank, can you repeat the question, please?
Thank you very much. So my name is Frank Onyambu from Kenya. My question is regards to the data that is generated in this project. Will this be publicly available? Will it be published, or this goes to proprietary databases? I'm asking this because I know there might be intellectual property that might emanate from some of these, for example, novel mutations that are found in the populations you find in Africa. Thank you.
Of course, the trial that will explore many aspects from a clinical and molecular profile will be an open trial, and the intellectual property, which is of course of the investigators, but also of the clinician involved in project in Tanzania, will be published data. I mean, the data will be shared with all the international community as all our trials.
Thank you, Dr. Crino. There is any more question? Otherwise, I can ask you, all of you, one question. Taking into account your high experience, what do you think is the main challenge for the collaboration in these kind of trials between Europe and African countries?
Thank you very much for this question. I think that putting European centers in direct relationship with African centers could give the latter the opportunity to do research project, to make a research project, and which otherwise would not have the opportunity to do. We could organize training courses, staff exchanges to do the exchange of expertise, and I think that it could be very important. I believe that the main aim of this European African collaboration could be to give African Center the opportunity to also to grow, the opportunity to have better therapeutic strategies, to better therapeutic approach for their patients, and so to give these countries the opportunity to participate in program with the final aim to improve their capacity of for the patient management and to improve survival of these patients.
Well, if I can add a very, very brief comment, it is a very ambitious project, in my opinion. We know that the potential of work and study in the sub-Saharan area are very, very high. And what is very interesting is that we have a very good basis because we have a very good relationship with our colleague in Moanza. So I think that the most important and most difficult question will be to organize the trial, to organize, to collect the data, and to do what seems to be very simple, just in telling, to realize it in a practical way. As always, the most simplest things are usually the most difficult.
Thank you, Dr. Crino. Just one last question for Dr. Apondo. And I would like to ask you, what can be the best approach for a researcher to face up with the ethical aspect in a clinical trial that are involved, or a clinical study that is involved with the new technology, the new digital technologies on personal medicine? What can be your piece of advice regarding this approach?
I think one of the things that we're learning from the work that we're doing right now is involving as large a number of stakeholders in the decision making as possible is important. I mean, most European countries have, and I mean, there are also international standards as far as tackling the ethical or identifying the ethical issues that come about with these studies are concerned. And I think the most important thing is really to try and look beyond just identifying individual ethical issues and trying to see what kind of interplay the different issues have and who else they could affect, which basically means just involving as many people as possible. And I mean, that has to do also with the question that was asked earlier on. I mean, it's not just an issue of publishing the results of the study in an international journal. The question is also whether the data sets themselves, where exactly they're going to be, and who is going to have access to them, and whether it will be possible through this access to be able to conduct further studies. And I mean, these are some of the questions that have not yet been sorted out. And I think the most important thing is just to involve as many people in the decision-making process and in the design of this study, as many stakeholders as possible. I think that goes a long way to kind of avoiding not identifying important issues. On top of course, the fact that you're going to have review boards or ethic commissions that are going to look over the whole thing and hopefully also ask critical questions about how most of these ethical issues that come about with data sharing, or rather getting data from one part of the world and using it in another part of the world, the questions that come about with that.
Thank you very much, Dr. Apondo. Then we have no more time, but I would like to show you these future initiatives that we are trying to organize with our colleague from Senegal. That is about the personal medicine ethics and regulation and the involvement of the ethical committees. Also the value of the personal medicine as a startup from our colleagues from Kenya. And we are also organizing a first training face-to-face event that will be more surely in South Africa. And the next year it is regarding the adoption and integration of standards in personal medicine research. Thank you really to all of you for your kind collaboration, and I hope we can meet together in the next webinar. Thank you very much.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye. Bye-bye.
Bye-bye.
Thank you. Bye.
Thank you. Bye-bye.